most concerned about? Give it a second. And like I said, this is a little bit experimental. I know we're not used to doing cases like this. So if it doesn't work in this format, it might just not work at this format, but I wanted to try it. Y'all are so quiet and shy. I'm going to show up there in person and make everybody speak. Oh, I love this. Yeah, Dr. Kong. So he also noticed that the temperature, like we talked about, one of the other signs of a very sick patient, temperature is 35. So this gentleman is hypothermic as well. And so he appreciated that. Yeah. And so like people are recognizing that this, at first glance, some of these other patients are concerning, but patient number one, if we think about some of those major causes of death in our trauma patients, the traumatic brain injuries and secondary causes of airway, patient number one is now kind of starting to look like maybe they have the most emergent problems. So this is kind of what I wrote as well when I was like, okay, I'm thinking this through. I think page number one, just based on what we have, needs a CT of his head, really kind of altered and confused. This is concerning. So he's getting intubated, and then we'll send him to the CT scan. All right. So let's consider him. Here, we're gonna do it this way. And then we're sending him to C scanner. So that was your first step. I like this. So now, so that is going, the nurse says, okay, we've taken him to the CT scanner. Now, of these other two patients, what are your next steps? Now that I can see my chat, I'm just gonna wait until someone pops it in the chat, and then we can talk about it. Anybody can. You guys have been there. Like I said, no wrong answers. You could make an argument for these are all very sick patients, and I'll tell you that they're all sick patients that will die. Each one of them will die if you don't intervene properly. But this is a good exercise to think about what needs to happen the soonest and what can you do between now and the future to keep this patient from dying. All right, yeah, EFAST. So EFAST. Okay, I like it. I like it. So yeah, ultrasound. I would also do the same thing. This is kind of what I wrote on my same thing. So people are saying get good IV access. So I agree. So both of these patients, 2 and 3, both have suggestion that they have some type of hemodynamic compromise, right? So just like we talked about, making sure we have large bore IV access, whether that is a 16, 14 gauge, a 9 French trauma line, something big. When they're truly crashing, intraosseous is okay too, and humerus better than tibia. But I agree, getting good access on both of these patients, because if they go south, we're going to need to be transfusing them, or we're going to be wanting to give them medicines. And then diagnostically, ultrasound is really going to be helpful. So this is exactly what I wrote on my notes to myself, is that so we're going to say large bore IV in both of them, right? And then, so in this patient in number 2, he has a positive fast. So he has, and then in this patient, she has decreased lung sliding and evidence of a hemothorax at the base of her lung. And she's very tender, so you have a high suspicion for rib injuries. So now what are your next steps? Popcorn, throw something in the chat. Throw anything in the chat. I love this, Dr. Hung. We oftentimes, cause we talk about pain management and we've totally we've overlooked giving these patients any type of pain management. So I actually really love that. We these are patients that are in a lot of pain, and part of our job is to reduce suffering. So I love that you're considering that in these patients. I think, oral medications, you might want to be a little bit careful in very sick trauma patients. Morphine is a good, like, I am not scared of morphine, but be aware that of the parenteral, the IV medications, morphine can cause a little bit more hemodynamic instability because it does have histamine effects as well. So sometimes you might have a little bit more risk of lowering their blood pressure with morphine. Sometimes we'll use, if you have access to it, we use fentanyl quite a bit because it's shorter acting, and as a synthetic opioid, it may have a less hemodynamic effect. Or if you have access to ketamine, we use ketamine a lot for pain management in our trauma patients because it also tends to have less hemodynamic compromise. But this is fantastic. It's a great answer because I hadn't even put it on my thing. I was again just thinking about diagnostics and treatments, but treating their pain is a fantastic thought. I love that. So let's add that on here. Let's give both of these patients some proper analgesia. And why don't we just, if we get 2 more entries in the chat of what you would do in your next steps, we'll talk that through, and then we'll kind of bring these cases to conclusion. Because I know you guys have all either worked overnight or are working. And so let's have, just give me 2 more things that we can talk about and discuss. And thoracentesis in 3. Yeah. Okay, I love that. I agree. So yeah, number 3 needs some sort of chest decompression, right? And so with the decreased lung sliding, we have a high suspicion for pneumothorax. That is maybe what's causing her hemodynamic instability. So I agree. Some type of chest decompression. And what we talked about, it sounds like, if you just have needle decompression as an option, then that's what you need to do. You can do finger thoracostomy, like we talked about, that where you just do the first part of the process, or actually put in chest tubes, which is a tube thoracostomy. So exactly. So I think those are what needs to happen in next steps before moving on. All right, I love this. And so, yeah, the ICU trained doctor definitely knows what to do here for the increased ICP. So, yeah, so we want to reduce, let's assume that this CT scanner shows, a traumatic subarachnoid with edema and shift, right? And so that means that our next steps are going to be neurosurgery consult, right? And any interventions that we can do to reduce the ICP. And so, we will, mannitol or hypertonic sodium. Do you guys, we tend to rely on hypertonic sodium. Is that your first go-to there, or are you using mannitol or something different? You thought you were done answering questions. I told you I would take too bored that I would stop asking you questions. Mannitol. Okay. Okay. And that's, a lot of this will be because even if you want to use something different, if your colleagues, if the other specialists use a certain medicine and the nurses are familiar with that medicine and the pharmacists are familiar with that medicine, oftentimes you just use what is clinically available. But hypertonic saline is kind of our primary go-to. So that for patient number one, they are going to need a neurosurgery consult because none of us can do the life-saving intervention, but that's how we keep that patient from arresting. Patient number two, with these vital signs, that exam and a positive fast, almost for sure, in my scenario, this patient, when you check his blood pressure again, it's much lower. So he's bleeding belly. He can't fix that directly, right? I need to consult the trauma surgeons, right? This patient needs to go for an exploratory laparotomy and trauma and damage control resuscitation. So we use the short-term XLAP for the exploratory laparotomy. And then, number three, she had broken ribs, and you identified her tension pneumothorax, and the thoracostomy resolves some of her immediate issues, and then she will get admitted to the hospital as well. So there is your exercise in kind of thinking through some of the priorities in all patients that are very, very sick and peri-arrest. All of these patients, if you didn't do the right interventions, would have had a cardiac arrest from their traumatic injuries. But they're all examples of patients that we can change their outcomes and we can make a difference. So I know that this talk is been a little bit different, but I didn't want to just talk about like algorithms. I didn't want to just talk about ATLS. I think it's kind of more useful. You guys are all very, very smart, experienced doctors. And I think sometimes trauma care gets reduced to algorithms, but I think we can still use our doctor brains. We can still be nuanced and sophisticated when it comes to our trauma patients. And so I think thinking through these things is a great exercise. So hopefully something in here, some parts of it somehow were helpful for you. I appreciate your guys' time. I'll turn off the sharing, and let me know if you have trauma patients they have questions about or anything, drop them in the WhatsApp chat. We can discuss patients in there. Any questions or thoughts before we say goodbye tonight or this morning? All right, fair enough. But thanks everyone for joining, and I am looking forward to seeing y'all in July, and we'll have some more teaching before then. So thanks for joining us, and we'll talk to you soon.
Thank you, Ryan.
Thank you.
Yes, we'll see you soon.
Recording stopped.